we'll be starting with our first talk, which is which is the need for extensive, expensive, elaborate lab tests and molecular diagnostic assays. Expert's view by Dr. Padma Malini Mahendra Das. This is covered under Back to Basics in Uveitis workup and its relevance in modern diagnostic armamentarium. So I'd request Dr. Padma Malini ma'am to please come on stage and deliver a talk. So this session is part of the IC, and it basically discusses the diagnostic methods in uveitis, in which we have come a long way now, and uveitis is no more dealt with steroids alone and no more an etiology-less entity. It has etiologies in most cases. We just need to find it using all the diagnostic methods smartly.
Very good afternoon to all of you. Thank you, Dr. Sumendra, for inviting me here. And I'll be talking to you on need for expansive and laboratory tests and modern diagnostic assays. Advances in medicine and technology have seen the emergence of many new investigative modalities, making it tougher for the ophthalmologist to decide what tests to order. New tests do not necessarily mean they are going to be useful in a clinical diagnosis. On the platter, we have different investigations available, either the skin test, serological test, imaging test, biopsy specimens, and molecular diagnostic tests such as polymerase chain reaction or PCR. So we need to tailor-make the investigation for each case and zero on the diagnosis. We need to remember all the tests share the false positive and false negative, understand the sensitivity and specificity of a test. Diagnostic tests have the most utility in confirming and rejecting the diagnosis. Coming to the diagnostic indications for molecular diagnostic tests such as PCR, whenever we suspect a case of an infective uveitis, or if the patient have atypical presentations, we do not know what we are going to deal with, or if the patient has multiple infections, you want to make sure which infection is there. If the patient is immunodeficient, with again, the chances of multiple infections are there. In extremes of age group with atypical presentations, when we suspect masquerades, definitely investigations plays a role. The PCR is a powerful method to amplify the specific sequence of the DNA. Normally we take about 0.1 ml, but minimum volume of 0.05 is sufficient to carry out the test. Now, next generation sequencing helps us to find out what kind of an infection the patient has. We'll move on to the case example. The first case is a case of a serpiginous-like choroiditis. Here, 26 years male, presented with defective vision in the right eye since 2 days. History of fever of unknown origin, for which he was treated with short course of antibiotics. This was treated at center elsewhere, where the visual acuity was 636, patient had AC reaction and also the anterior vitreous cells. They also noticed absent color vision in the right eye. This is the fundus photograph where we could see the yellowish lesions in the posterior pole with ILM folds, looks like a choroiditis. The OCT, in that we could see the outer retinal changes with distortion of the ellipsoid zone. In the investigations, they noticed increased total count and ESR CRP was elevated. They investigated along the line of post-fever retinitis and all the tests were negative. They treated the patients with systemic antibiotics and steroids. Patient showed improvement and noticed the resolution of the perifoveal lesions. This is the picture when the patient presented to us. After stopping the steroids, 3 days later, they noticed extensive increasing in the lesions and they referred to us. Clinically, it looked like serpiginous, like placoid form of chorioretinitis. Systemic steroids were restarted and patient was referred to the pulmonologist to start empirical anti-TB drugs. Following 2 weeks, we could see the resolving lesions of the placoid lesions with pigmentation. we did notice linear track like lesions in the retinal periphery. The picture is different. So at this point of time, we did the AC tab for PCR, which came, in addition to the TB, the viral genome was done because of the dendritic pattern of the lesion. So herpes simplex 1 came positive by PCR. We did start the patient on systemic valacyclovir, and ATT was continued, following which we could see the 2 months post-recurrence healing lesions in both eyes. So this particular case, when a different pattern of a lesion develops, is important. We need to re-evaluate the patient and treat the patients appropriately. Next case is a case of a post-fever retinitis. A 32-year female software engineer came with the complaints of defective vision in the left eye for the past 4 days. She had performed visual fields elsewhere which showed left inferior immunopia. She had history of fever, headache, vomiting 10 to 12 days back. She had a contact with pet cat. The cat was sick at that time and no history of travel. On ocular examination, the visual acuity was 615 in the left eye. There was a defective color vision 16/21 in the left eye by Ishihara plates. Anterior segment was normal. This is the fundus examination. The right eye was absolutely fine. In the left eye, she had vitritis. There was a disc edema and peripapillary lesion was seen. Tortuous vessels were also seen. So this is a OCT showing posterior vitreous cells, subretinal fluid, intraretinal fluid, disorganized retinal layers with inner retinal thickening with aftershadowing was seen. And there was SRF and also the intraretinal fluid was seen in the fovea. Post-fever retinitis was suspected. When we did the investigations, she had increased brucella IgM was positive, serum homocysteine was elevated, ESR was raised. Urine showed pus cells, however the urine culture and sensitivity was negative. MRI brain was ordered, which showed focal enhancement of the optic nerve, suggestive of papillitis. So based on the serological titer and the clinical picture, the probability of brucella neuroretinitis was made, and she was put on doxycycline and oral steroids were continued. Follow-up visit, you can see resolving retinitis in the left eye, and there was increasing in the color vision, and the visual acuity was improved in the left eye. 10 days post-presentation, we could see the persistence of SRF and inflammations in the left eye. This is 1 month picture. By now, we got the report. This time, what happened, Bottonella came positive, which was ordered at the time of contact with the sick cat. So we had already brucella was positive. Now we got the Bottonella. What are we dealing with? So when we repeated the test of brucella, instead of increasing the antibody titer, the titers were disappeared. So then we assumed this secondary to Bottonella because the patient had history of contact with the sick cat, peripapillary lesion, and Bottonella came positive both for IgG and IgM. We referred the patient to the infectious disease specialist, and she started the patient on rifampicin and doxycycline. She continued for about 2 months. This is the follow-up 3 months picture, showed resolution of the lesions with complete improvement in the visual acuity, improvement in the color vision. So post-fever retinitis had a varied etiology, but in this particular case, history of contact with the sick cat gave us a clue with the peripapillary lesion with the neuroretinitis kind of a picture secondary to Bottonella. This post-treatment picture showed resolving retinitis. We'll move on to the next case. Third case is a challenging case. It's a case of a bilateral outer retinitis due to viral. 8-year-old boy from the southern state of Karnataka presented to a clinic with a sudden painless decrease in vision since past 3 days. Absolutely, completely blind the child. The mother revealed the history of fever and swelling near the ear the child had. But however, she did not take the child to the doctor. When we probed the history, was there any other history? Then she told the patient's sister had a fever. She took her to the pediatrician and they diagnosed it as a case of a mumps. She was put symptomatic treatment, so she gave the same tablets to this child. And also, in addition to her kids, the other surrounding also, there was a lot of mumps cases in their region. The child was vaccinated up to the age in the government scheme. Examination, hand motion was present, and color vision is absent. IOP was normal. Anterior segment examination shows corneal pigments on the endothelium. Anterior vitreous cells were seen. This is the fundus examination picture where we could see the cerebriform pattern of retinitis with perivascular clearing. It was seen in both eyes. OCT shows posterior vitreous cells, distortion of the retinal architecture, and hyperreflectivity of the inner and outer retinal layer. Left eye shows distortion of the retinal architecture with hyperreflectivity in the inner and outer retinal layers. The peripheral retina also showed the similar changes. So we made the clinical diagnosis of bilateral outer retinitis secondary to the mumps virus. So coming to the investigations, the basic investigations were within normal limits. The serum IgG and IgM we ordered. Empirically, because it's a viral, we started the patient on acyclovir, and patient was referred to the pediatric and also the neurologist. The examination, the patient went to consulted the neurologist after 4 days. So child was conscious and well oriented. By then the visual acuity has dropped to perception of light. They've ordered the MRI brain and spine and CSF analysis. MRI brain and spine were normal. However, the MRI T1 weighted axial scan showed increased uptake in the parotid gland, bilateral parotid gland. Increased uptake was noted. CSF analysis was normal. So CNS involvement of the mumps was ruled out. Patient was started on IV methylprednisolone and referred back for the follow-up. However, the patient presented to us after 2 weeks. So by then the visual acuity's perception of light and anterior segment findings were the same. The child has developed temporal disc pallor with the narrowing of the retinal vessels and sclerosis of the vessels in both eyes. So we could see the resolution of the retinitis lesions. And also the OCT outer retinal changes were started disappearing. By then we got both mumps, IgM and IgG were positive. So this patient had history of fever with parotid swelling, multifocal retinitis. OCT shows outer retinal changes. MRI showed parotid gland involvement with positive IgM and IgG antibody. We made the diagnosis of bilateral outer retinitis secondary to mumps. Patient completed the remaining dose of IV methylprednisolone, started on oral steroids. When we looked into the literature, we also noticed the Kerala group used hyperbaric oxygen therapy for the treatment of mumps retinitis. So we started this child on hyperbaric oxygen therapy after taking the detailed consent from the parents. After 2 weeks, because the patient did not improve, this is 1 week post hyperbaric oxygen therapy. We had the post hyperbaric oxygen. We felt there was significant improvement. The visual acuity has improved to 612 in both eyes. So there was hyperpigmentation near the perioral region which you noticed. Anterior segment was fine. However, we could see the chorioretinal changes, scars-like lesions started developing in the periphery. So at that point of time, because patient had increased pigmentation in the fundus and also in the perioral region, we stopped the hyperbaric oxygen therapy for 1 week. Autofluorescence shows hyperautofluorescence lesions in both eyes. FFA shows staining of the scars and the choroidal vessels, both FFA and ICG in both eyes. So due to the development of chorioretinal scars, we advise the patient to stop the hyperbaric oxygen therapy. Review the patient after 1 week. By then, we noticed there is a drop in vision in the right eye. Fundus looks more or less similar. So we restarted the patient on hyperbaric oxygen therapy along with continuation of the oral steroids. So following which, we did notice the improvement in the visual acuity in the left eye. The right eye did not improve. And this is the picture where you have a temporal disc pallor with multiple chorioretinal scars in both eyes. This is a follow-up OCT picture and autofluorescence picture. For academic interest, we did the BEP, which showed delayed latency with reduced amplitude, fulfilled ERG, undetectable photopic response in both eyes. Multifocal ERG showed light response in the central area, which is responsible for 6/9 vision in this child in the right eye. So this is a summary. History of fever and the parotid gland swelling gave us the clue, possibility of a mumps we are dealing with. Serology helps us to diagnosis and treated the patient with IBMP followed by oral steroids. Because the child did not improve as a rescue, we put the child on hyperbaric oxygen therapy and we found to have improvement in the visual acuity, especially the central vision in the left eye. So, yeah, before ordering any test, we need to ask, will it identify any underlying systemic disease or process, association, or will it provide definitive diagnosis, or it's going to reject the diagnosis, how it's going to help the management of the patient. So detailed history, thorough clinical examination still remain the most important diagnostic tool for the Uveitis specialist. Avoid investigations that do not either assist in finding the cause or in the management of the condition. We need to tailor-make the list of investigations according to the clinical picture of the patient. So order expensive tests only if the clinical picture demands the condition and it's not refractory to treatment. Thank you for your attention. Happy to take up any questions.
So very interesting cases, Dr. Padma. How often do you see a mixed etiology, like the first case that you showed? The patient was beautifully responding to ATT and steroids and then subsequently came with those dendritic lesions, and then you thought of a viral etiology. Because very often as clinicians, when we are dealing with a patient and we find that the patient initially whatever the presentation was and they start responding, we usually will not really go and look for some newer etiology. So that was something very observant of you, that you picked up those lesions and then you got a PCR done which came out positive, and then subsequently the patient was started on antivirals. So in your practice, how often do you really come across this superimposition of another etiology over a pre-existing etiology?
It's a rare entity. The percentage of mixed one is very, very less. I have seen with tuberculosis with toxoplasmosis, and one more case I've seen it in the past, treated as a TB and turned out to be a viral. It's important in the viral, when they start showing the changes, when you put them on appropriate antiviral therapy, we can preserve the vision. But if we miss the bus and they end up causing structural changes, then the visual improvement is not so good. But percentage of viral etiology causing SLC is less. Majority we treat them for tuberculosis.
So I think all your case examples beautifully tell us that as you go along managing the patient, probably you need to keep seeing what the patient is having, and according to that tailor-made the investigations, rather than ordering a whole battery of investigations where quite a lot of things may come out false positive also. And then probably we get totally lost at what we are dealing with.
Yes, especially for this particular child, I did not do an ACTAF for PCR. I know that we are not dealing with herpes or CMV. It's an unnecessary procedure and cost to the patient. So that's why we ordered for the serology of the mumps. And once it comes negative, so we went ahead with the neurological and other systemic management.
So thank you so much, ma'am. I think all the points were beautifully elucidated. Thank you, Manisha ma'am, for pointing them out. Thank you, ma'am. Our next speaker will be Dr. Mudit Tyagi, and he'll be discussing the role of multimodal imaging in uveitic diagnostics. Does it add value? Does it make a difference? Dr. Mudit will tell us.
All right. So good afternoon. First of all, let me thank Sambreen for having me as a part of this great IC, and to the scientific committee and the chairs for allowing me to talk on this. So I will be talking on the role of multimodal imaging in uveitis. Does it add value and does it make a difference? Now, what do we mean when we say multimodal imaging? What that essentially means is when different imaging scenarios, different imaging modalities come together, whether it's in the help of a fundus photograph or an autofluorescence or an OCT, FFA, dye-based angiography, ultrasound B scans, when all of them come together cohesively and help us in identifying and in treating our patients. So that is what multimodal imaging essentially means. And how can we use multimodal imaging in uveitis, and what is its role, and how much of an advantage does it give to us as clinicians is what we will see with the help of a few examples. Let me start first with this very basic, early, simple slide. But before that, what are the roles and how do we use multimodal imaging in our clinics? The first and foremost role of imaging is, number one, to identify what we are dealing with. What's the disease that we are dealing with? So it helps in identifying a lot of our diseases, identifying the extent of the disease involved and also the pathogenesis, what's happening as far as the disease is concerned. the activity of the disease, and sometimes subsequent complications that can ensue in the course of the disease. So those are the scenarios where imaging comes to our help. So let me show you first a very simple example. This is a slide which has been shown to us by Dr. Avinash Padange, and I owe this slide to him. So this is basically how do you differentiate on clinical and imaging analysis between retinitis, choroiditis and a posterior scleritis on the basis of an FFA alone. So two important points. Look at the intensity of early hypofluorescence and the pattern of early hyperfluorescence, and I will come to that with example. So in retinitis, the intensity of early hypofluorescence is the maximum, followed by choroiditis and then scleritis. And look at the pattern of early hyperfluorescence. So early hypo and early hyper. Look at the intensity of early hypo. Look at the pattern of early hyper. If it is perilesional, you are dealing with a retinitis lesion. If it is intralesional, choroiditis, and scleritis, as we all know, will have pinpoint lesions. So let me show it over here. So this was a patient with retinitis. Look at the early hypo. The early hypo is the maximum over here in retinitis as compared to what you see in a choroidal lesion over here. But look at the pattern of the early perilesional hyperfluorescence. So there is a perilesional hyperfluorescence that occurs in a retinitis. As compared to that, in a choroiditis, what you see is a diffuse intrastromal hyperfluorescence. So early hyperfluorescence is perilesional in retinitis and intralesional in choroiditis. And scleritis, obviously, like we have discussed earlier, will have multiple pinpoint leakages. And when you add to it an ultrasound B scan which shows this characteristic subtenuous fluid and what we describe as a T sign, all of those come together to help us arrive at a diagnosis of a posterior scleritis. So just based on imaging, we are able to arrive at what essentially are we dealing with. Is it a retinitis or a choroiditis or a scleritis? Moving on to some common diseases that we encounter in our clinics. If you look at this eye over here, what you see is a placoid chororetinitis with intense infiltration at the edges. Now clinically we have learned to identify this pattern as being something which is characteristic of ocular syphilis. But when you add an OCT to your clinical examination, what you find is this diffuse RP nodularity. So you put both of these together, an OCT which is showing RP nodularity and photoreceptor damage, and a fundus photograph or a clinical appearance of a placoid chororetinitis. Both of them come together and help us at arriving at a diagnosis of the fact that we are probably dealing with ocular syphilis. So it helps in narrowing down our differentials. It helps us in arriving at the etiology of what we are dealing with. Similarly, you see these multiple miliary lesions. Now, miliary lesions have been actually described in different uveitic entities. There are people who have even described it for sarcoidosis. But once you do an OCT through these miliary lesions and you see a full thickness retinal involvement, that is pretty characteristic of syphilis again. So you see these multiple miliary lesions and you see an OCT passing through them showing a full thickness retinitis. Again, it clinches our diagnosis as what we are dealing with is syphilis. So again, multimodal imaging helps us in arriving at the diagnosis of the underlying disease. In terms of retinitis lesions, when you do an OCT, you see this area of necrosis, but you see predominantly not only the extent of involvement in terms of the layers of the ocular area which are involved. So you see a full thickness retinitis, you see some amount of fluid over here, but you also see a choroidal involvement. And when you see a retinochoroiditis, you can differentiate it from the other lesion, which is a viral necrosis. And in viral retinitis, usually you will not see a predominant choroidal involvement. So you get an OCT done, you see a choroidal involvement along with the retinal involvement. It helps us in differentiating between a viral retinitis and what you're dealing with in terms of this being a toxoplasma retinochoroiditis. Similarly, in inflammatory diseases like VKH, when you see these multiple neurosensory detachments, adding an OCT helps us in appreciating these RP undulations, hyperreflective dots in the choroid, and that kind of helps us in assessing the fact that this is a case of VKH. And I'll show you how OCT also becomes important in assessing the response to treatment in some of my next few slides. Also, there are occasional times when you may have a diagnostic conundrum. Sometimes, very rarely, a multifocal CSR also may mimic a VKH. And therefore, looking at subtle signs like fibrous septa, RP undulations, choroidal granularity, along with absence of pachychoroid, helps us in differentiating the fact that we are dealing actually with VKH and not with a multifocal CSR. The diagnosis will also help us in determining a treatment. Steroids obviously are contraindicated, or rather not to be given in CSR, whereas they will be the treatment of choice in case of VKH. So it's important for us to differentiate between these two entities, which may both present with subretinal fluid with some neurosensory detachments. So like I said, how you differentiate acute VKH from acute CSR, you see these RP undulations over here, you see some inflammatory signs, you see this neurosensory detachment and a bacillary layer detachment. All of those will be absent in an acute CSR, and that will help you in differentiating between these two entities. Some more disease where multimodal imaging helps us in understanding what is actually happening to the disease. So this was a patient with a progressive outer retinal necrosis, and what we found was a full thickness retinal involvement with extensive necrosis. This was a kid who was immunosuppressed, was treated subsequently with gencyclovir, but OCT very clearly helps us in assessing the layers of the retina involved. So the point which I am trying to make again and again is that imaging comes to our rescue not only in identifying the disease, but in also understanding what are the layers of the retina and the choroid and the uveal tissue which are involved, and can then help us in arriving at not only our treatment diagnosis, but also in tailoring our treatment accordingly. So one more case, this was a patient who came with a history of fever a month back, now comes to us with these multiple hard exudates, some area of fluid, one area over here of these subretinal and preretinal hemorrhages, one small area of retinitis. And when we did an OCT angio, what we found was this angiomatosis over here, which could be very nicely delineated on this OCT angiography. This was a case of Bartonella, which was treated subsequently and responded. So OCT angiography over here helped us in appreciating this angiomatosis and arriving at a diagnosis of Bartonella. One more very interesting case, this was actually a high myope patient who had presented to the clinic with a decrease in vision in the left eye and was initially suspected as having a myopic CNV in the left eye. But the point to note over here is that what is happening to the right eye? The right eye vision, and now the patient tells us, has gone down in the last 1 week from 20/30 to 20/1200, improving to 20/400 on pinhole. And now when you do an imaging, this is what the autofluorescence reveals. A diffuse area of hyperautofluorescence. This was a patient who was having an RP epithelitis, and this patient was subsequently, because he was not responding and the lesions were not regressing, treated with systemic steroids. And let me show you what happens after some time to these lesions after we started the patient. But the point is that if you look at this photograph, you see the vision has gone down, and while you may appreciate that there is a small faint lesion over here, an autofluorescence very brilliantly demarcates what is happening, and we have seen some beautiful images of subregions like choroiditis in the previous talk. So these imaging modalities help us in appreciating also the extent. So let me show you what happens over there. But the OCT through these lesions again showed this RP nodularity and some damage happening at the level of photoreceptors. So that is how multimodal imaging can help us in arriving at a diagnosis of what is the disease that we are dealing with. Moving on to the fact that it can also help us in appreciating the extent of the involvement and the extent of the inflammation that is happening. So this was a patient who was seropositive, came to us with a sudden decrease in vision, and you can see a very small subtle retinitis lesion over here. But when you do an autofluorescence over here, you can see the extent of involvement. This was a patient who had developed a toxoplasma retinochoroiditis. She is seropositive, immunosuppressed, develops a lesion now over here, which was, the PCR came positive for toxoplasma, was treated with Bactrim DS. But look at how brilliantly the multicolor imaging reveals the extent of the lesion. So while on a naked eye or just a cursory fundus evaluation, we may try to probably underestimate the amount of involvement, a multicolor imaging very nicely reveals the extent of the photoreceptor damage and the extent of RP damage and the extent of the lesion which has happened over here. This is how the OCT reveals this area of full thickness retinitis, some area of ensuing necrosis, hyaloid getting adherent over here. This patient was subsequently treated with Bactrim DS and did subsequently improve, came back with a vision of 20/20 finally, but is on a maintenance dose of Bactrim DS. Again, moving on to subregions like choroiditis, and in choroiditis, autofluorescence helps us in assessing the extent of involvement. We have now noticed that eyes which have got this extensive hyperautofluorescence at the edge of the lesion, or what we call the double ring of hyperautofluorescence, are eyes which end up having a higher propensity of paradoxical worsening, and also eyes which will probably need a long-term immunosuppression and a prolonged treatment duration. So autofluorescence not only helps us in identifying the extent of disease, it can also help us in identifying and tailoring our treatment approaches. Moving on to activity and complications. We have already seen the role of autofluorescence and OCT in identifying the disease. Let me also show you how OCT angiography can actually help. So a choriocapillaris regeneration is a sign of healing. So when you do an OCT angiography through these lesions, what you can see is this area of healing edge, and this area can easily help us in assessing the fact that our patient is now responding to treatment over here. So choriocapillaris recovery has been described very characteristically as a sign of healing of these choroiditis lesions. Apart from autofluorescence patterns which we have already seen. Also in eyes which of weak age, a lot of times your patient may have a good visual acuity but may come with a sudden decrease in vision, and while on an examination you may not find anything else, but you will find a thickening of choroid in some of these cases. And apart from thickening of choroid, ICG angiography, though I have not shown an image over here, will help us in appreciating these multiple small granulomas. So ICG angiography in cases of chronic weak age is a very important tool in assessing the persistence of granulomas, which will help us in determining or deciding whether we need to stop immunosuppression or do we need to continue with it. And along with that, if new granulomas are appearing, then it's a clue to the fact that we need to step our immunosuppression. So again, imaging comes to our rescue in assessing our response to treatment. So we were discussing about VKH earlier, and resolution of RP undulations is one of the first signs in assessing the treatment response to VKH. So this was a patient of VKH. The moment the patient was started on steroids, I'll just take one more minute. You can start seeing the regression of these lesions over here. Similarly, you can assess the response to treatment in case of this toxoplasma retinitis that we had seen earlier. The lesion starts regressing, but even on OCT, you can see the fluid regressing, the retinitis regressing, and eventually a scar formation that happens over here. One more very important investigative modality is OCT angiography in assessing the presence or absence of inflammatory CNVM. So you may have patients of choroiditis who have got a quiescent disease, that there is no activity, but may suddenly come with a decrease in vision. And because of the scarring and the complexity caused by the underlying inflammation, you may not be able to appreciate some of the subtle CNVMs. But an OCT angiography very brilliantly will pick up the fact that there is an underlying inflammatory CNVM, and then your treatment will also involve anti-VEGF injections and not just the control of inflammations. So the last point, if you remember the case of RP epithelitis that we had discussed, was started on steroids, and now autofluorescence can be used to assess the response. Look at how the autofluorescence starts regressing, visual acuity reduced, improved from 2400 to 2060, subsequently 2030. So this is how the patient was at presentation, 1 week, 2 months, and at 5 months. So essentially, imaging also helps us in monitoring the response to treatment. So in a nutshell, multimodal imaging helps us in not only identifying these diseases, it helps us in understanding the extent of the disease, and also in assessing the disease activity and complications and response to treatment. Thank you so much.
So thank you, Mudit. I think you've shown some beautiful examples of various cases of uveitis. And I think one important message which comes out of your entire presentation is that one is that we should not feel handicapped if we don't have expensive imaging modalities. I think 80% of our uveitis cases we can diagnose and manage based on our clinical examination and our index of suspicion, where we should have a differential diagnosis. I think it's only 10 to 20% is going to be contributed by various imaging modalities and lab investigations, which can help us to confirm what we are clinically suspecting. And there can be very subtle things which can be confusing when we do a clinical examination, and probably that is where we need to clinch the diagnosis based on the multimodal imaging that you have shown.
Exactly. So most of these diagnoses, and a lot of these points are clinical clues. Once we start getting into the habit of assessing this, and I believe a fundus photograph, autofluorescence, and OCT are predominantly now available with a lot of our ophthalmology colleagues. So while we may say that OCT angiographies and ICGs may be something which may not be there with everyone, but a basic fundus autofluorescence and fundus photography is usually very easily available. And not only, even if that's not there, a good clinical evaluation and picking up these clinical clues in itself can help. So imaging will probably come, like you said, as an addendum to our clinical clues and can help us in overcoming some of the dilemmas.
Definitely, Dr. Mudit. There is no substitute for a good clinical examination, because we have such a huge array of investigations and diagnostic modalities available that you cannot apply everything to a case.
True.
You first clinically assess and then you decide what you're going to be using in your case.
Exactly.
So thank you for beautifully bringing out the ways how we can use these modalities to diagnose our patients effectively. Thank you so much.
Thank you so much.
Now, moving forward in our IC, the next speaker is Dr. Nitin Kumar, and he will be taking you back to the basics and discussing the role of naming and meshing in uveitis case workup, outlining basic clinical workup and its relevance. Dr. Nitin, please.
So Dr. Nitin is a young enthusiast uveitis specialist from AIMS Jammu, and he has an excellent training done at PGI Chandigarh.
Thank you,
And
ma'am.
Shankar Netralaya, of course, he's a student of JB sir.
Yes, ma'am. Thank you so much. So, in the last session only, we had a very important discussion that there is no substitute to a good clinical history and examination, and most of the diagnosis can be made on the basis of history and examination only. So, I will be highlighting these in my this presentation. So, as ma'am has also told previously that history and examination can establish almost diagnosis in about 70%, 70 to 80% of the cases of uveitis. So, what constitutes a basic uveitis workup is very important to be highlighted. So, we have to pay a very stress on the history, review of systems, a good ocular examination, and we have to find out where the intraocular inflammation is exactly there in the eye. So, we have to classify whether it is limited to anterior segment or posterior segment, or the whole of the eye is involved, that is the pan uveitis. And this should be followed by a very good systemic examination, and I will be talking about what is exactly naming, meshing. And in the previous talks you have just seen that there are so many diagnostic imaging modalities as well as tests are coming up, and the technology is evolving every day. So, but again, why classify? It will be very, if this we pay attention to this image, it will be easy to find a book which has been arranged in the library rather than this stack. So this is why we have to classify our patients of uveitis to find out the diagnosis. Previously it was thought that most of the diagnosis, most of the uveitis is idiopathic, but now we have come to know that there are so many diseases which will lead to intraocular inflammation. So coming to these two images, we can see that they have similar kind of presentation. Both have a hypopyon uveitis. So in these kind of situations, we will have to go back to our history and a good clinical examination. Why we should do naming and meshing in our basic uveitis case workup? There are numerous disease associations and varied etiologies. These can be infectious, non-infectious, as well as immune mediated. And different entities may have a similar clinical presentation, like which I have shown in the previous slide. And this can lead to diagnosis being very challenging, and also there can be some diseases in which there will be systemic involvement also, and others which will be limited to the eye only. So if we have to solve a problem, first we will have to define the problem. So this is where naming comes into the picture. And then when we have done naming, we will have to compare this with known etiologies, known patterns, to find out in which pattern our patient is fitting. How do we do meshing? So this is based upon the demographics of the patients, and then we have to ask about the severity, chronicity, establish the laterality of the disease, pathology of the disease, and again where the disease is located. We all know that certain kind of diseases will be common in a certain age group, like GI is more common in children, parasitic uveitis, HLA associated uveitis is more common in cases of adults, and in old patients there can be masquerades as well as this herpes zoster ophthalmicus. Similarly, certain diseases will be more commonly associated with a certain gender, like VKH is more common in females, autoimmune diseases are more common in females, and males they may have more of sympathetic ophthalmia due to the injuries to the eyes. Again, socioeconomic status will have an implication about the parasitic diseases. And again, these thing is also very important. So we again, if I highlight that based upon the symptoms, we can see which part of the eye is involved. Like pain and redness is more common in anterior uveitis, floaters will be more common in intermediate uveitis, and posterior uveitis can lead to decreased vision. Limited duration of the disease, whether it is less than 3 months, persistent, greater than 3 months, whether it has been an acute onset of the disease or this has been a chronic disease, Again, in cases of HLA-B27, the patient will be exactly knowing the day and the time when the disease started. So this is how we can just probe into the history and arrive at a case profile of the patient. Again, whether the disease was mild, moderate or severe, and what is the pathology, whether it is granulomatous or non-granulomatous. And we have to arrive at an etiology, whether it is infectious, non-infectious, there has been some history of trauma, or the patient belongs to extreme of the ages where masquerades are common. Anatomic classification is also very important. So these are some examples how we exactly do it. So we have to, just like this, the example is there, a 9-year-old white girl with moderately severe acute bilateral non-granulomatous hydrocyclitis with mild bilateral band-shaped keratopathy and occasional right pain. So this will lead us towards a diagnosis that this can be probably JIA. And similarly in other examples, like if we see a young white woman with mild chronic unilateral non-granulomatous kind of a uveitis with elevated IOP, cataract and heterochromia. So this will help us to just narrow down on our diagnosis. Again, then we have to compare those with the common uveitic entities and the signs and symptoms of those diseases, which are seen in this busy slide. So if there are some dendritic ulcers that are commonly seen in viral uveitis, so we will compare our case to what is already known. Like iris atrophy is more common in case of viral anterior uveitis. Again, focal retinitis, that may be in patients of Behçet's and SLE. And diffuse retinitis, which can be seen in acute retinal necrosis. So in some of these diseases, you don't need to do these fancy tests to get to a diagnosis. Only a good clinical history and examination will lead you to the diagnosis of the disease. So we'll come back to the pictures which I had shown you. So these are two cases with the hypopion anterior uveitis. Hypopion uveitis, sorry. So we don't know, without fundus examination we can not know whether it is anterior uveitis or whether it is involving the posterior segment also. So this is how we should do it. So if we see, this was a 23-year-old male, Asian, who had severe kind of this uveitis, although in this image that fibrin is retracting, but when he had initially presented, the whole anterior chamber was full of the fibrin. So this was a non-granulomatous, there were no KPs, and this was primarily involving the anterior segment. When we did a fundus examination for this patient, there was no involvement of the vitreous, neither there was any lesion in the retina. So again, when we did a review of the systems, the patient gave specific history of morning stiffness, and there was backache. So these will lead us to a diagnosis. And then only we have to do some specific tests. For when the patient had given this history, then we did a single test, HLA-B27, and advised for MRI. So this can help us to reduce the burden to the patient also, do specific imaging as well as systemic tests for these patients. And this one turned out to be Behçet's, because as a part of the clinical examination, we saw that if we can see, there was this hypopion was mobile, and the patient had history of oral and genital ulcers also. So history and a good clinical examination will lead us to diagnosis in most of our cases. Thank you so much.
Thank you, Dr. Nitin, for such a comprehensive presentation, which takes us back to the basics of uveitis. I would like to request our audience if they have any questions, because this is... Yes, ma'am.
This is about empirical treatment for suspected tuberculosis. Sometimes, we get cases which, it's a recurrent granulomatous uveitis maybe with a little bit of choroiditis, and it keeps coming back. And there's nothing on the test. We send them to the pulmonologist, they check for chest x-rays and it's negative. The MAN2 is positive, but then we're all probably positive. And I'm not getting anything else. And nowadays, empirical treatment you can't just give without some data. So what do you do in these cases when you have a really strong suspicion, but you're not getting anything?
I'd request Manisha ma'am to please answer this query.
So ma'am, that's a very valid question that you have raised. And most of our physicians don't understand that you can have ocular tuberculosis without any evidence of systemic TB, and that is where the problem is. Because we have a very strong suspicion, but we send them, they say there's no evidence of systemic TB. Now here comes, I used to face the same problem when I started practicing. The physician has to work very closely with you and rely on your findings and clinical suspicion. And nowadays, the physicians, they know that you can make a diagnosis of ocular tuberculosis. If you are going to be sending to a person who's a pulmonologist, not seeing patients very frequently of ocular TB, he's not going to believe you. But like we are working very much closely with the physician, he knows now that we are able to detect. When we tell them that please give a trial of ATT, they rely on our findings and start on an ATT trial for 2 months. And once we get a good response, we then give a full course. But that is the only solution. There's no other way out.
So empirical treatment even without positive A is now.
Absolutely, absolutely, yes.
Thank you, ma'am. So if we don't have any other questions, we can move on to our next talk. This is Losing Control in Complex Uveitis Cases by Dr. Manisha Agrawal. Ma'am is a renowned vitreoretina and uveitis specialist heading the VR and uveitis department at Shroff Charity Eye Hospital. Ma'am, we'd be delighted to listen to you. Can we have the presentation, please?
So very good afternoon to all of you, and thank you, Samendra, for making me a part of this wonderful IC. I think my timer is not right. I have 14 minutes, you've put it on 8. So I'll be basically sharing a few case examples where the diagnosis was a dilemma, and that is where the thought process comes, whether you would really like to take another opinion or send the patient across to somebody else. Can I have my slides moving, please? So my first patient is a young 3-year-old girl child presented with pain and redness in the left eye for last 4 months and diagnosed 4 months back as a case of anterior uveitis not responding to treatment. She was put on prednisolone, and because of the topical steroids, she was already having a secondary glaucoma which was being treated with 2 anti-glaucoma medications. And on examination, when this child presented to me, child had this fluffy white material in the anterior chamber, which was anybody can confuse it like a very extensive uveitis entity having a lot of fibrinous reaction in the anterior chamber. But what we need to really question our mind is, somebody having anterior uveitis, why will the child not respond to topical steroids? If it's inflammatory, it has to respond to steroids. And that is where you don't really need to step up the steroids, add oral steroids, but actually question the diagnosis, because nobody is going to be making such a blunder. When I did a cursory examination in the OPD, the central fundus was all normal. We did a B scan. The B scan was also normal because the child is not very cooperative. We did all the baseline investigations, and everything came out to be normal. So this is the time when you have to take a call and say, okay, I have done an examination, but probably that's not enough, and that's how I planned this child for an examination under anesthesia. And what I found was that the ciliary processes also were studied with the similar kind of white fluffy material. Now, it's a question whether we want to again subject this child to another GA and think what we need to do, or take a chance and do an AC tap. And what you have to be cautious is, like I think Nitin also mentioned, when you have any patient of extremes of age, too young or too old, they are unlikely to have an inflammatory response. And what you have to keep in mind are the masquerades. So I did an AC tap and I did a long intracorneal track, thinking that it might come out to be something as a surprise, using a 30 gauge needle to avoid any kind of metastasis. And rightly so, this child showed up these numerous basophilic cohesive cells, very much suggestive of a retinoblastoma. Now, what was surprising was, on a fundus examination, there is absolutely no evidence of retinoblastoma. On a B scan also, there is no evidence. But here we are, our AC tap is showing these malignant cells. So this child underwent an enucleation, and we sent the eyeball to JB sir. and he confirmed that we were in fact dealing with retinoblastoma, and also the histopathology confirmed that beyond doubt this was a retinoblastoma. Since the optic nerve head, which was free of the tumor, nothing else was required. And then we reviewed the literature where we went wrong, and it came out to be an entity called diffuse anterior retinoblastoma. And what is surprising in a diffuse anterior retinoblastoma is that they have microscopic foci of the tumor involving the retina. We all know retinoblastoma is a tumor of retina, so it should show up in the retina. But why it didn't show up? Because this entity has microscopic foci, and which are very subtle and you may not clinically pick up. So this is something we have to keep in mind when we are having. So what were the lessons learned from this? It was a young child with very unusual fluffy exudates in the anterior chamber, not responding to steroids for last 4 months, already developing complications in the form of a secondary glaucoma. Now it is the time to revise diagnosis or send it for another opinion, or do an interventional diagnosis in the form of an EUA that we did, and we also did an AC tap. So that is the time when you have to think of some other diagnosis. My slides are again not moving. Now coming to the second case. So this is an 18-year-old boy, not vaccinated with BCG, having a diminution of vision for last 6 months. And in the left eye, what you see is a hyperemic disc, so you know you're dealing with an inflammatory pathology. You have an exudative RD, and you also have the subretinal yellowish lesion in the macular area. And the vision is as low as hand movements close to face. So I go ahead, I do a fundus fluorescein angiography, which just shows a hot disc with stippled hyperfluorescence, suggestive of, again, nothing very conclusive, but some inflammatory pathology is all that I know. So I have to draw a kind of a differential diagnosis in my mind. So the first thing which comes in India is tuberculosis, chronic infections like fungal, and something lower in the DD list is a lymphoproliferative disorder. But to my surprise, when I investigate this child, the Mantoux is 0, which is very much against a diagnosis of a tuberculosis. So again in this child, I subject this child to a vitreous biopsy. So again an interventional diagnosis. I go ahead, I collect the sample of the vitreous right above the lesion. Where we go wrong is when we do an AC tab, which will just suck out the clear fluid. When we do a vitreous biopsy, we'll take the sample of the anterior vitreous, though the lesion is lying at the back. And I collect the sample and I subject it to the investigation. So my lab technician tells me that the acid-fast staining is negative and the PCR for MTB is also negative. So I'm again lost in the diagnosis. And now the sample starts showing some kind of a growth on the culture plate. And you have gram-positive filamentous bacilli, and it comes out to be a nocardia species, which again was not in my mind because I've never seen a patient of nocardia. So when we reviewed the literature, we realized that there can be an involvement of CNS by nocardia. So we went ahead and did an MRI of the brain to rule out intracranial nocardiosis, and we put this patient on the specific treatment along with Visalon, and the child responded well, and we also published this case because it was a learning for us that nocardia can actually resemble a tubercular infection by having a subretinal abscess. So here, as the title suggests by Samendra given to me, here we retained the case and we did an interventional diagnostic vitrectomy and lab testing to make a diagnosis which was definitive and helped in the management of this young child. Now coming to my next case, a 45-year-old female patient with diminution of vision in both the eyes for last 4 months, diagnosed to have VKH elsewhere, given 3 doses of IVMP followed by oral steroids and not responding, and then put on methotrexate, and then again was not responding, so was put on azathioprine. Still not responding and with no improvement of vision, and this lady was apparently known to some employee of mine in my hospital, and he said, "Aap ek dafa dekh lijiye, patient is not doing well." I was just questioning VKH diagnosis. I've never heard not responding to steroids and to immunosuppressants was something which was really taxing in my mind. There was no relevant past systemic history in this patient. So the vision was 1/60, less than N36, no evidence of any inflammatory cells, no evidence of any retinal break, extensive exudative retinal detachment. I depressed and depressed to locate a retinal break which would have solved my problem. I could see extensive subretinal gliotic bands. I could see a hyperemic disc, but I could not see any retinal break or a dialysis. And this is the left eye picture. The vision was 624 N18. You see this thick band, SRG band going through the macular area, and extensive retinal detachment, a hyperemic disc, which again was confusing in my mind that it's an inflammatory pathology. So I go ahead, I do an OCT. My problems increase further because I see this lesion, which resembles a PED. I see a bacillary layer detachment, which goes in favor of inflammatory pathology. A PED goes in favor of CSCR. I see a subretinal gliotic band, which goes in favor of a rhegmatogenous retinal detachment. So I had my mind boggling with all kinds of diagnoses. I see these septas, which go in favor of a VKH. So I just didn't know what I was dealing with. I did a fundus fluorescein angiography. The disc was hyperemic. The disc was hot. It showed some kind of leakage, and I had this diffuse kind of hyperfluorescence throughout the fundus. But it really didn't add to my diagnosis. I just noticed this pinpoint leaks, which go in favor again of a VKH or a posterior scleritis, but I really don't know what I was dealing with. So I put these questions in my mind: no response to steroids including IVMP, no response to 2 immunosuppressants. So I reassessed the OCT images again. When you have a very busy OPD, you don't spend so much of time when you have done an investigation. So a good idea is send back the patient, sit in the evening and reassess the investigations that you have done. And what I saw in this particular patient was, if you very carefully see the OCT, these subtle bumps, what I noticed, and that was something which was really bothersome, that this is not something we see usually when we are dealing with an inflammatory pathology. So I called the patient back, and I took a detailed history taking again from this patient, and she told me that she had a small nodule in the right breast 2 years back, which was diagnosed to be benign. I frankly wanted to buy time. I didn't know what diagnosis I was dealing with, so I said, okay, let's start from here. You go back and get your breast lump again reevaluated by your oncologist. The oncologist saw her, and to my utter surprise, this patient was lost for a follow-up. A good idea is to take up the phone number or the contact details of the patient. And when I called up, the husband picked up, and he said, when I went back to the oncologist with my wife, she was diagnosed to have lumps in both the breasts. She had matted axillary lymph nodes, and she was advised a whole battery of investigations. And finally, she was diagnosed to have invasive ductal carcinoma grade 3 with leptomeningeal metastasis and both eye choroidal metastasis, along with bone metastasis. And she was put on hormonal radiation and chemotherapy. As far as the ocular treatment is concerned, since we are dealing with an exudative RD, we tried doing an external drainage, but because we had lost so much of time and there were subretinal gliotic bands, the retina would not settle with an external drainage, and finally I had to resort to a pars plana vitrectomy with silicone oil injection in both the eyes, which made the patient ambulatory, but we lost this patient in 6 months' time because we lost a lot of time initially treating her as a patient of VKH. And this is her 6 weeks post-op follow-up, where you find that the vision is considerably okay to make this patient ambulatory. So the clinical pearl to learn from this last case of mine is that the patient is not responding to treatment. It's time to revise your diagnosis, restart by taking a detailed history from the patient, run through all the investigations again peacefully, and take an expert opinion if your mind is getting blocked with a certain diagnosis. I remember my professors telling me, don't fall in love with the diagnosis that you have made, but you have to revise it if your patient is not doing well on the treatment that you have started, because you may have something very fatal which can really go wrong for your patient in future. So I would just conclude my talk by saying that any case of uveitis not responding to treatment, it's time to revise the diagnosis or take another opinion or refer the patient. Dealing with extremes of age of the patient, you must rule out the masquerades, and I'm sure Dr. Samendra is going to add more knowledge on masquerades. And if it is not diagnosed and treated on time, it at times can be fatal, like the last patient I showed to you. Thank you so much for your patient listening.
Thank you so much, ma'am, for sharing those unbelievable cases. Sometimes they make you question the very basis, the very concept of uveitis that you have learned. But the idea is to keep revising and, like you said, not to fall in love with your diagnosis, because it's always, you can always revise it,
So
go
here
back
you can fall in love with every day with a new diagnosis.
with a new diagnosis.
Right.
Thank you so much. So,
Thank you.
can we have some questions? Dr. Nitin
Yeah.
has a comment to make.
Ma'am, in your first case, what is the role of ultrasound biomicroscopy in such kind of patients when there is nothing at the posterior back
So in
segment?
ultrasound biomicroscopy will surely have a role, but what happens is that here you had just fluffy material which was along the ciliary processes. And the other thing is that if it would have been an adult patient, we probably could have been able to do a UBM in our OPD. But here you had a 3-year-old child who would not have cooperated for a UBM without a GA, and we unfortunately don't have a UBM in our OT. So if an adult patient, surely yes, I would advocate doing a UBM.
Thank you, ma'am.
Thank you, ma'am. Can we have some questions from the audience regarding this kind of a case? I can see Dr. Ramakumar sitting in the audience. So, any comment from you? Okay, all right. So, we'll move on to our last talk of the session.
I will invite now Dr. Samain, and he is going to be telling us more about masquerades. When everyone thought it was non-responsive uveitis, the enigma and dilemma of a masquerade.
Thank you so much, ma'am. So you've already set the ball rolling, ma'am, and I hope I can add a little bit more to it. Good afternoon, everyone. Masquerade is basically a term which is often used in terms of a cancer presenting as uveitis. But with this presentation, I'd make it clearer that it is not just cancers, and it has much more than the eyes can see. So mask is something that hides the real identity. So in uveitis, what are the things that hide the real identity of a uveitis or present as uveitis, but it is not? So there are two basic subgroups of masquerades. One is a non-neoplastic subgroup, which all of us come across in our practice. A trauma, intraocular foreign body, which present with cells, they can present as masquerades because they are not autoimmune in nature. Pigment dispersion, so the cells are pigmented cells, again, present like uveitis. Retinitis pigmentosa has cells, again, it's not uveitis. Ocular amyloidosis, ocular ischemic syndrome, rhegmatogenous RD, all of them have cells, but they are not primarily uveitis. So the idea when we deal with these kind of entities is to know what kind of cell we are dealing with. Whether we are dealing with a white blood cell, a red blood cell, pigment epithelial cell, RP cell, or a tumor cell. And with the modern slit lamp with high magnification, it is quite possible to differentiate what kind of cell you are dealing with. Another subgroup of masquerades are the ones which we come across in neoplastic entities. So they can be primary intraocular lymphoma, primary vitreoretinal lymphoma, primary uveal lymphoma, leukemias, or metastatic solid tumors. And in children, we come across retinoblastoma, like ma'am just showed in the previous case, Coats, juxtaxanthogranuloma, and medulloepithelioma. So this slide basically gives an overview of the ocular lymphomas. So they are primarily either anatomically they can be divided as iris, ciliary body, choroid, or the ones involving vitreous body, retina, or optic nerve. So the ones which involve the iris, ciliary body, and choroid can be grouped as uveal lymphomas, which could be primary low-grade lymphoma or secondary from a systemic high-grade lymphoma. The posterior segment involving vitreous body, retina, and optic nerve are grouped as vitreoretinal lymphomas, of which primary vitreoretinal lymphoma is the one which we often see in our OPD, where the first presenting sign is actually the vitritis or the cells in the vitreous. Others can be ocular involvement of primary CNS lymphoma, where the entity begins in the CNS and then involves the ocular tissues later. or a secondary from a diffuse large B-cell lymphoma. So just to illustrate what I've discussed, I'll show a case where a 65-year-old Asian Indian female presented to us, and she had a complaint of diminution of vision and floaters for a year, insidious, gradually progressive. She was a hypertensive, rest of the systems were normal. She had multiple consultations in several clinics, but there was transient or no relief at all. Several courses of topical oral steroids, including PST. So everywhere she went, the next physician gave her a newer modality of steroids. She was even diagnosed with both eyes primary angle closure glaucoma, chronic iridocyclitis, and laser PI was also done. And currently, when the patient presented to us, she was on anti-glaucoma medication. The vision was 618, 69, pressures were moderately controlled. She had KPs, pigments on endothelium, and some cataract. She, on fundus examination, she had dense vitreous membranes with vitritis, which were more in the right eye compared to the left. We subjected her to a thorough uveitis workup, which turned out to be negative. This is the anterior segment. Although we did give her some topical steroids, we didn't want to hurry or rush into giving her oral steroids because she had received so many forms of steroids already. So this is the picture after topical steroids. The fundus shows in the red glow that there are some vitreous membranes, some pigment depositions on the endothelium. The FFA wasn't much revealing because of the dense vitritis in right eye, and left eye showed some faint vascular staining. This is the clinical course. The IOP remained controlled. However, the vision kept on deteriorating in front of our eyes. She had large mutton fat KPs initially, with dense vitreous membranes. So we were a little confused whether she's having uveitis or she has pigment dispersion glaucoma. We were really not sure, but we knew that we are dealing with something unusual. At this point, we started thinking that this is not the run-of-a-mill entity, and we need to start thinking of unusual entities. And this is the first time when I thought, because she is an old lady, non-responding vitritis, thought of primary vitreoretinal lymphoma. We planned a vitreous biopsy, and so this is a brief video where we did a vitreous biopsy. We generally do our biopsies under air so that we can receive pure vitreous. So the yield or the PCR yield becomes, or the cytology yield becomes much more because we have received a pure sample and not a diluted sample. So as the air bubble keeps expanding from the infusion, we lower our cutter and keep going back as we reach close to the retina. And when we have we can get about 0.4 ml sample with this technique quite comfortably. You can see some fluffy deposits over here, this area. So apart from this, there was no other finding in the fundus. So we subjected it to cytology, and we saw some large cells with hyperchromatic nuclei and scanty basophilic cytoplasm, but the diagnosis was not very clear. Anyway, we subjected her to neuroimaging. MRI brain was reported normal, and left eye vitreous biopsy also we did, which was also reported normal. So right now, we had no clue what we were dealing with. Patient was exhausted, and she did not follow up for some time. However, she came after a couple of months with recent onset forgetfulness and left-sided headache and periorbital pain. The ocular exam was okay. I again told her to go and consult a neurologist and get an imaging done, which they refused because they had just got an MRI done 3 months ago. Patient probably went back home at this stage. Then, not so much to our surprise, patient landed back in emergency just after about 15 days with left side hemiparesis and slurring of speech for 5 days. Emergency CT scan revealed this large lesion in the left brain. Immediately, the patient had to be taken up for neurosurgery because there was some uncal herniation which was associated. The squash cytology suggested a neoplastic lesion with morphological features of high-grade malignancy. Tumor biopsy and histopathology showed the neuroparenchyma, which was diffusely infiltrated with neoplastic lymphoid cells. Immunohistochemistry confirmed our doubt, and it was a LCA positive CD20 B cell and negative for CD3, suggestive of a right temporal diffuse B cell lymphoma. Finally, the diagnosis was made and the patient was diagnosed with high-grade NHL B cell lymphoma, currently receiving radiotherapy and chemotherapy, and patient is doing well. We didn't feel the need for any intravitreal methotrexate because there were absolutely no lesions or findings in the fundus. So all cells are not inflammatory. There has to be a very high index of suspicion for picking up masquerades. In the era of MIVS, we shouldn't hesitate to take a sample, and we should always believe in our clinical judgment. Thank you so much.
So thank you, Samendra. I think my talk and your talk both have done the job, that everything is not uveitis, and we have to be very observant and careful if a patient that we had diagnosed as uveitis is not responding to steroids and to immunosuppressants. And I think both of us have highlighted that it's time to revise the diagnosis. Either we take another opinion or do an interventional diagnosis in the form of vitrectomy. And I think you've beautifully highlighted again that it's good idea to collect an undiluted sample with an air infusion. If you're dealing with or having a suspicion of lymphoma, then we have to stop steroids at least 14 days prior to taking the vitreous sample and transport those samples very fast to the lab because the lymphoma cells are very fragile. And unfortunately, all of us do also face this problem in our clinics, that despite we having diagnosed lymphoma, the neurologists don't believe that the patient is having lymphoma, and we've all lost a few of our patients because of late diagnosis and late management. But I think this is something we all need to keep in mind, and we have to be careful before, it becomes fatal. So any questions from the audience, we would be very happy to take them up. So Samendra, would you like to wind up the session?
So thank you all so much for being part of this IC, where we dealt with the basics of uveitis all the way to masquerade. And thank you so much for Dr. Manisha ma'am and Dr. Padma for their expert comments and the analysis of the cases and the talks presented by us. Thank you all the speakers, Dr. Nitin, Dr. Mudit, and thank you AIOS for giving us this opportunity. Thank you all so much.
Thank you so much.